Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast. This episode will focus on nuclear medicine therapies for thyroid disease. Upon completion of this topic, I will have reviewed on recent episodes nuclear medicine therapy for prostate cancer, neuroendocrine tumors, and thyroid diseases. I hope these episodes have been and will be helpful for many of you. Quick reminder that you can follow at RadRevPodcast on X or on Instagram, where on most days I am posting some sort of educational fact or content. You can also follow my personal Twitter account at mfcovington if you feel so inclined, where I post many of my own thoughts on things like breast cancer imaging, as well as some of the latest presentations and things I may be involved with. I'm also always happy to connect with people on LinkedIn, so if you want to connect in those ways, please feel free. I also want to remind you that on my website, theradiologyreview.com, there is a discount code section where I frequently have discount codes for things like resources for radiology board review and radiology education. Also check out some of the articles at the Radiology Review Insider, and if you are interested in submitting an article for the Radiology Review Insider, I'm always open to consider content and topic suggestions. If that is something that is interesting to you, send me a message at theradiologyreview@gmail.com. Without further ado, let's get into the content for this episode. First, some background. Iodine 131 administration has been used to treat benign and malignant thyroid disorders since the 1940s. I-131 is of value as well for thyroid imaging, along with iodine 123. I have presented information on I-131 for thyroid therapy within my prior episodes titled Nuclear Medicine and the Thyroid, Parts 1 to 3, with emphasis on thyroid treatment, especially in Part 3 of those previous podcast episodes. If you want to check those out, you can find them on my website or search somewhat far back in the history on your podcast viewer, and you can find these episodes. A study guide on these topics is also available on my website, theradiologyreview.com, or contained within my book, The Radiology Review Board Exam Study Guide, episodes 1 to 101, which you can buy on Amazon if you think that might be helpful for you. However, I didn't exactly cover the topic of I-131 therapy in as much depth as I think I could have for the core exam, as well as nuclear medicine board exams. So I am diving into this topic further. This contains substantial new information in comparison to the prior episodes on this topic. I will also repeat some of the key questions from the prior episodes for completeness' sake. Nuclear medicine thyroid therapies is a frequently tested topic from my experience, so I think this content will be helpful for many of you as you prepare for board exams. Note, this information is for educational purposes only. Variations do exist in diagnostic and therapeutic uses of radioactive iodine for thyroid imaging and therapy, so my intention is to provide a general overview of key concepts for board preparation purposes. Institutional and medical society guidelines must be referred to and strictly followed for any diagnostic or treatment decisions in clinical practice. First question. What are the most common thyroid disorders for which I-131 therapy may be utilized? First, malignancies, most commonly papillary and follicular thyroid cancer. Next, benign disease, such as hyperthyroidism from Graves' disease, solitary autonomous hyperfunctioning nodules, and toxic multinodular goiter, or for treatment of benign non-toxic nodular goiter. The therapeutic goal of treating various causes of hyperthyroidism is to achieve a euthyroid state or else to induce a state of hypothyroidism because of therapy that can subsequently be treated with oral levothyroxine to achieve a euthyroid state. The therapeutic goal for treating a non-toxic nodular goiter, and non-toxic means it is not causing hyperthyroidism, is simply reduction of thyroid size and volume to alleviate local compressive symptoms from the large goiter in the neck. The therapeutic goal for treating thyroid malignancies is typically for curative intent in many scenarios when combined with surgery and other appropriate care, or else to improve treatment outcomes and reduce morbidity and mortality for more advanced thyroid malignancy. Next question. What are the energies and half-lives of iodine 123 and iodine 131? All right, energies and half-lives of nuclear medicine radiopharmaceuticals are important, and radioisotopes, so let's get into these ones here. Iodine 131 has an energy of 364 keV and an 8-day half-life. Remember, I-131 is the beta emitter and therefore the therapeutic agent of these two isotopes of radioiodine. I personally remember I-131 as 365 keV because that's like the number of days in the year, and a 7-day half-life because that's like 1 week. And, you remember it's just slightly off from that, but that should get you typically close enough to answer board review questions. So I-131, 364 keV, which is super close to 365, and an 8-day half-life, which is super close to 1 week. For I-123, this has a 159 keV energy and a 13-hour half-life. If you look at the numbers 1, 2, 3, that has a 1 at the beginning and a 3 at the end. And if you can look at that, you can extract the 13-hour half-life from I-123 by focusing on the leading 1 and the terminal 3. And for the 159 keV, you're just going to have to remember that one. One tip is to remember it is close, but slightly higher to technetium at 140 keV, and that can help you select the correct answer from a multiple choice question stem. I-123 provides overall superior image quality compared to I-131, but cannot be used for therapy and is typically more expensive than I-131. One other thing I would perhaps remember is that I-131 is reactor-produced, meaning nuclear reactors, and I-123 is cyclotron-produced. Next question. What are common pharmaceuticals that block radioiodine uptake, and how long must one abstain from these prior to radioiodine administration? First, I would remember methimazole and propylthiouracil. They do interfere with radioiodine uptake, and one must abstain from these typically about 3 days prior to radioiodine administration. Next, Synthroid or other thyroid hormone replacement, for which you should typically withhold for something like 10 to 14 days prior to I-131 administration. Multivitamins with iodine should be withheld something like 7 to 10 days. Next, Lugol's solution, that's L-U-G-O-L, Lugol's solution, which is a saturated potassium iodide solution, should be withheld for about 2 to 3 weeks. Topical iodine for surgical skin preparation, you can actually absorb some of this, and you should not have that within 2 to 3 weeks of I-131 therapy. Iodinated contrast agents, super important to remember this. The board exams often ask about this. If you've received iodinated contrast agents, especially if water soluble, which is most common, if you have normal renal function, you cannot have I-131 within something like 6 to 8 weeks. Some institutions may prefer even longer periods. And if you've had more historical lipophilic iodinated contrast agents, Sometimes the period before you can receive radioiodine administration can be as long as 6 months. That can vary. I think most important is just to simply remember that if you've had a contrast-enhanced CT scan, that can potentially interfere with I-131 therapy uptake, and that is something that needs to be checked for and appropriately handled prior to I-131 therapy. Finally, and another highly tested concept is amiodarone use, because this has a lot of iodine, and if you've had amiodarone, you typically need to wait something like at least 3 to 6 months before you would have I-131 therapy, and some say you need to wait even longer. We will talk a little bit more about what to do if people are unsure whether they've had something like a contrast-enhanced CT in the recent past, but we'll withhold going into that discussion for a few moments. Next question, true or false? I-131 therapy is always contraindicated in pregnant individuals. The answer here is true, and this may go against common test-taking practices where when you are asked an absolute, the question is often false, meaning if you see the word always or never, very frequently the answer may be false because there are not a ton of absolutes in medicine, but this is one that is absolute. I-131 therapy is always contraindicated in pregnant individuals. The fetal thyroid gland can take up and concentrate iodine by about 10 weeks of age, and I-131 therapy would ablate the fetal thyroid, which should always be avoided. Next, how long must one abstain from breastfeeding after receiving iodine 131? After receiving I-131, breastfeeding must cease for that child. This is due both to the long half-life of I-131 of 8 days, as well as the risk to the child's thyroid of ablation and becoming hypothyroid as a result. We want newborn babies and children to have normal thyroid function, so we need to avoid exposing them to I-131. I-131 is contraindicated in pregnancy and in childhood. I-131 therapy should furthermore be withheld until lactation ceases to minimize radiation exposure to the breast tissue itself. During lactation, this increases the exposure and dose the breast will receive from I-131, and this generally requires waiting 4 to 6 weeks after breastfeeding stops. If there is a question of whether the breast tissue is still concentrating iodine following lactation cessation, breast uptake can actually be assessed at time of radioiodine uptake and scan by looking for uptake in the breast tissue on the images. Next, what are common precautions that patients must take before and following I-131 therapy? Prior to therapy, patients must discontinue use of iodine-containing medications, as we've already discussed. A state of iodine deficiency is also desired for which a low iodine diet for something like 7 to 14 days prior to therapy is often recommended. If there is concern whether a patient is in a true iodine deficient state, such as with somewhat recent iodinated contrast administration or amiodarone use, a 24-hour urine iodine excretion test can be helpful. For board exams, know that following I-131 therapy, a patient must isolate for 3 days, including bathroom hygiene, sleeping alone, no exposure of others to bodily fluids, including saliva and urine. Additionally, patients should stay well hydrated. Many additional recommendations exist which can vary between state and institution. Written instructions should be reviewed and provided to the patient and any caregivers prior to I-131 administration. One word of advice to current residents is that you have likely only seen to this point how your own institution handles precautions for I-131 therapy. I can tell you from experience at multiple institutions that I've had during training and employment, these recommendations do vary in certain ways between institution to institution. So there's no one-size general exact recommendation that everybody in nuclear medicine or nuclear radiology agrees on. But I've covered some of the key concepts that I think are most likely to be tested on board exams. Again, refer to your own institutional as well as societal guidelines when you are counseling your own patients on I-131 therapy. Next, true or false? A patient can ingest non-iodinated salt without specific restriction prior to I-131 therapy. The answer is true. An iodine-deficient diet does not equal a low-sodium diet, but the salt that is ingested should be non-iodinated to the maximal extent possible. Next question. What is thyroid stunning? Thyroid stunning is a reduction in I-131 uptake below predicted values following a low-dose diagnostic I-131 scan. The thought is that either reduced cell function and or cellular death following a diagnostic I-131 scan, such as an I-131 uptake study or whole body search, can lead to reduced therapeutic I-131 uptake due to these so-called stunned or even dead thyroid cells secondary to the initial I-131 low-dose study. Whether thyroid stunning occurs in a clinically significant manner, especially with low-dose I-131 administrations for imaging, or even possibly I-123 administration, is somewhat controversial. Nonetheless, I would understand the concept for radiology and nuclear medicine board examinations. Next question. What are NRC guidelines for releasing a patient following I-131 oral administration? First, no individual of the public is likely to receive more than 5 millisieverts exposure from the patient treated with I-131. Second, when a survey meter reading at 1 meter is less than 0.07 millisieverts per hour, which is the same as 7 millirems per hour. And 3, when administered activity is 33 millicuries or less. Note that if administered activity is over 33 millicuries, then you need to definitely check with the survey meter to make sure that the reading at 1 meter per hour is less than the values I just specified, and that no individual of the public is likely to receive more than 5 millisieverts of exposure from the patient treated with I-131. Prior to release, the authorized user should instruct the patient regarding best practices to minimize radiation exposure to others, and written instruction describing recommended methods to limit radiation exposure to others is advised. Precautions include having the patient sleep alone, avoid pregnant individuals and children, avoid public transportation, follow strict bathroom hygiene, and so forth. Note also that I-131 exposure is at high risk through bodily fluids, but not through touching an object. For example, a family member does not need to worry if they touched a door handle that was recently touched by the person treated with I-131. All right, that concludes the first section on general questions about I-131. Let's now dive into questions specific to I-131 treatment of thyroid cancer. What are common I-131 doses for thyroid cancer without nodal or distant metastatic disease, thyroid cancer with local nodal metastases, and thyroid cancer with distant metastases? Again, my intention here is to give you representative ranges to help you on radiology and nuclear medicine board exams. So for I-131, therapy for contained thyroid cancer, post-thyroidectomy with no nodal or distant spread, a dose of 50 to 100 millicuries, some say 30 to 100 millicuries, is typically utilized. I-131 for thyroid cancer and local nodal disease in the neck typically requires a dose of 150 to 200 millicuries. I-131 for thyroid cancer and distant metastatic disease often requires a dose of 200 millicuries or higher. This may require dosimetry. For example, if there are lung metastases that could pose the risk of post-radiation pulmonary fibrosis, or if there is risk for bone marrow suppression following I-131 treatment, dosimetry should be utilized to select the maximal dose that can be used while still limiting these important toxicities. Next question. The American Joint Committee on Cancer, which is the AJCC, divides thyroid cancers into groups based on risk of recurrence and risk of dying from thyroid cancer that range from very low to high risk. Can you describe what thyroid cancers have high risk per the AJCC? High-risk tumors include, for those under the age of 45, tumors that have distant metastases, tumors with extension to the muscle or invasion of prevertebral fascia or subcutaneous soft tissues, or invasion of the larynx, trachea, esophagus, or the recurrent laryngeal nerve, or tumors that encase the carotid artery or mediastinal vasculature. For those over the age of 45, high-risk tumors include tumors that extend to muscle, invade subcutaneous soft tissue, the larynx, trachea, esophagus, or recurrent laryngeal nerve, prevertebral fascia, or encase carotid or mediastinal vasculature, as well as any distant metastatic disease, as well as a follicular carcinoma larger than 4 centimeters. That was a lot of information. Go ahead and listen to that question and answer again, or refer to the free downloadable study guide on this topic that you can access on my website, theradiologyreview.com. Next question. What is the potential role of recombinant human TSH, which is also termed thyrogen, for patients undergoing I-131 therapy for thyroid cancer? When I-131 is administered, you want thyroid cells to be primed to take up the I-131 to promote effective therapeutic delivery. Thus, you want TSH levels to be high so that the thyroid cells are stimulated to take up as much iodine as possible. For patients on thyroid hormone replacement, this can be achieved by thyroid hormone withdrawal, although symptoms of withdrawal and subsequent hypothyroidism can be unpleasant for the patient. Withdrawal periods of something like 10 to 14 days for T3 replacement and something like 3 weeks for T4 replacement are often necessary to achieve desired TSH elevation. Alternatively, you can give intramuscular injections of recombinant human TSH, which will artificially increase TSH levels in circulation and prime thyroid cells to increase iodine uptake. Note that a minimum TSH value of 30 is often considered acceptable pre-I-131 ablation, and a TSH value of 50 or higher may be considered ideal. Next question. What subtypes of thyroid cancer classically may not take up I-131? I would definitely remember that medullary thyroid cancer and anaplastic thyroid cancer classically may not take up I-131 and therefore may not respond as well to I-131 therapy compared to other types of thyroid cancer. I would also remember the commonly tested multiple endocrine neoplasia types 2A and 2B association with medullary thyroid carcinoma. Note that medullary thyroid cancer has neuroendocrine features and may have uptake on an MIBG, octreotide, or somatostatin imaging examination, or somatostatin receptor imaging study. Papillary thyroid cancer is typically radioiodine avid. Next question. What other factors contribute to treatment resistance of thyroid cancer to I-131 therapy? First, patients with prior I-131 therapy are more likely to be resistant to I-131 therapy in the future. So, if you are retreating with I-131, you often need to significantly increase the I-131 dose for subsequent therapies. Prior methimazole treatment is also thought to possibly contribute to resistance to I-131 therapy, and of course, poor patient preparation is also a cause of failure or poor response to I-131 therapy. Next question, true or false? The hurdle cell variant, that is HURTHLE, of follicular carcinoma has a worse prognosis than a standard follicular carcinoma. The answer here is true. The hurdle cell variant is a higher risk subtype of thyroid cancer, and it typically does have a worse prognosis than standard follicular carcinoma. Next question, true or false? For thyroid cancer therapy, thyroidectomy typically precedes thyroid treatment with I-131. The answer is true. Thyroidectomy is first performed and I-131 is subsequently given to ablate any residual thyroid tissue in the setting of thyroid cancer. Note that it is not possible, even with the most skilled surgeons, to remove all thyroid tissue at surgery, so there will always be a thyroid remnant that can be ablated. As there can be variation in how much thyroid tissue remains post-thyroidectomy, one can perform a thyroid uptake test with I-123 or I-131, and if thyroid uptake is something like 5% or greater in the neck, those patients may be at risk for thyroid pain following I-131 therapy and may be considered for something like steroid treatment during I-131 therapy to reduce symptoms, or else, if there is significant thyroid tissue remaining, one may need to return to the operating room to remove additional thyroid tissue. Next question. How might a pre-therapy thyroid scan be helpful to guide I-131 therapy for thyroid cancer in a patient after thyroidectomy has been completed? First, in nearly all cases, not all thyroid tissue is removed at thyroidectomy, as we've already said, and estimating the degree of residual thyroid remnant is helpful. Again, if significant thyroid tissue is present, this may indicate a need for a completion thyroidectomy, as administration of I-131 in high dose for a patient with significant residual thyroid tissue could have unacceptable risk of symptomatic radiation thyroiditis. Additionally, the pre-ablation scan may change the patient's staging by indicating nodal or distant metastatic disease that was previously unknown, which would change the dose of administered I-131 to higher dose levels compared to disease without local or distant metastases. Whether pre-ablation imaging is performed by planar imaging or also includes SPECT-CT combination imaging may vary by institution. Note that information regarding potential local nodal metastatic disease in the neck could also be obtained on thyroid ultrasound and ultrasound of the neck, as well as MRI or CT imaging. Next question, true or false? I-131 therapy can be considered for radioiodine avid brain metastases. The answer is true, but this can vary depending on disease extent. Steroid treatment along with I-131 therapy will typically be considered to reduce degree of swelling in the confined intracranial space. Next question. What are some of the important potential side effects of I-131 therapy for cancer treatment? Because I-131 doses for cancer therapy are higher than those used for hyperthyroidism, more pronounced side effects may be seen in this setting. These include things like oral mucositis, sialoadenitis, loss of taste, and painful thyroiditis. Painful thyroiditis is more common, again, if there is significant remnant tissue following thyroidectomy, and can also have things like associated recurrent laryngeal nerve paralysis and neck swelling. If there is concern that painful thyroiditis or other more severe symptoms may occur, steroid treatment along with the I-131 therapy may be considered. To minimize side effects, robust hydration and frequent urination can also be helpful. Some advocate for agents to stimulate flow of saliva, such as a sugar-free candy, though I've heard others say that increased salivary flow could theoretically increase dose to the salivary glands. In severe cases and with higher administered doses, salivary gland damage and xerostomia can result. In cases of nausea, antiemetics should be provided. In high-dose cases, meaning even doses as high as 150 or above 200 millicuries, transient decreases in white blood cells and platelets may occur. That in some instances require supportive care, but this is rare if pre-therapy blood counts are within normal limits. Next question. After I-131 therapy for thyroid cancer, when should a whole-body iodine scan be performed? Typically, 3 to 7 days after I-131 therapy, a whole-body scan should be performed for staging purposes, wherein you are imaging the distribution of the I-131 that was administered and absorbed for therapy. This means that you do not need to re-administer I-131, as the therapeutic dose of I-131 will still have enough I-131 present for imaging purposes. This scan, post-therapy, will image with higher activities, in fact, than are present on pre-treatment imaging, and the sensitivity for detection of metastatic disease will typically be higher. Remember that septal penetration artifact, which has a star appearance over the thyroid remnant, is common, as is some degree of low-level salivary and GI activity. Next, what should you consider if thyroglobulin levels are rising in a patient who has completed thyroidectomy and I-131 ablation for thyroid cancer, and the thyroid I-123 or I-131 scan is negative? What is the next best test to consider? This is a very important concept. If thyroglobulin levels are rising in a patient who has completed thyroidectomy and I-131 ablation, and the thyroid scan is negative, you need to consider the possibility that the thyroid cancer is truly back, as suggested by the thyroglobulin levels, but has dedifferentiated and therefore no longer takes up radioactive iodine. In this setting, one would want to perform an FDG PET-CT study to show where the sites of recurrence are, as dedifferentiated thyroid cancer tends to be FDG avid. Last and final question on I-131, specifically for thyroid cancer. What is the significance of anti-thyroglobulin antibodies? Anti-thyroglobulin antibodies, if present, make thyroglobulin levels potentially false negative and make thyroglobulin a potentially inaccurate test for monitoring of thyroid cancer recurrence. Essentially, thyroglobulin is only produced by thyroid cells. So in a patient post-thyroidectomy and ablation, thyroglobulin levels should be nearly undetectable. Thyroglobulin levels should be assessed prior to I-131 ablation and can be measured both with and without TSH stimulation, and can thereafter be again measured post-I-131 ablation therapy as a baseline measure. This lab value of thyroglobulin can thereafter be used as a biomarker, or in newer language, a liquid biopsy test to monitor for recurrence. If thyroglobulin rises, thyroid cells have recurred, and this is evidence of recurrent or worsening disease. However, if anti-thyroglobulin antibodies are present, the immune system can clear thyroglobulin from the body, and this is therefore not a useful test for these individuals with anti-thyroglobulin antibodies, as thyroid cancer could recur without any remaining thyroglobulin signal due to immune clearance of the thyroglobulin precluding laboratory detection of rising levels. Therefore, testing for anti-thyroglobulin antibodies helps inform whether thyroglobulin is likely to be accurate for recurrence in case of no antibodies or not, meaning anti-thyroglobulin antibodies are positive. Note also that outside of the setting of thyroid cancer, anti-thyroglobulin antibodies can also be a sign of autoimmune thyroid damage, such as with thyroiditis from Graves', Hashimoto's, subacute thyroiditis, or even with lupus or type 1 diabetes. Let's now complete our discussion and review by discussing treatment of benign thyroid diseases. First question: what are general dose ranges for I-131 therapy of Graves' disease, autonomous hyperfunctioning thyroid nodule, and toxic multinodular goiter to keep in mind for board exam purposes? With Graves' disease, a dose of 5 to 15 millicuries of I-131 is typically utilized. For autonomous hyperfunctioning thyroid nodule, this is often treated with 15 to 25 millicuries of I-131. And for toxic multinodular goiter, this is often treated with something like 25 to even 35 millicuries of I-131. I would generally remember that Graves' disease often requires a slightly lower dose than autonomous hyperfunctioning thyroid nodule, and that requires often a slightly lower dose than that used for toxic multinodular goiter. However, calculations do exist whereby doses may be calculated based on thyroid weight and radioiodine uptake values. However, these general dose ranges are something that may be beneficial to know for board exam purposes. Next question: in what scenarios may a treating physician consider using somewhat higher doses than is standard for treatment of hyperthyroidism? Patients with very large toxic diffuse goiters, patients with prior I-131 treatment yielding insufficient response, and patients with rapid iodine turnover, meaning that the 4-hour uptake exceeds 24-hour uptake, may be considered for higher I-131 doses than for standard cases. Next question: how long after I-131 treatment for hyperthyroidism does it commonly take for a patient to become hypothyroid? It often takes 2 to 3 months following therapy for a hyperthyroid patient to become clinically hypothyroid. Therefore, laboratory monitoring is required after treatment, and thyroid replacement with levothyroxine or similar should be started when TSH becomes elevated and may need to be subsequently titrated to ensure the patient is euthyroid and symptom-free. Next question: what are classic severe toxicities that can result from treatment of hyperthyroidism with methimazole or propylthiouracil? The side effects I would most be aware of for board exams are potential hepatotoxicity and agranulocytosis. Next question: what is the so-called thyroid storm that can result after I-131 therapy for hyperthyroidism? As I-131 destroys thyroid cells, they can release stored thyroid hormone into circulation, which can worsen symptoms of hyperthyroidism or, in extreme cases, cause thyroid storm, where severe symptoms can result from the sudden release of thyroid hormone. Risk factors for thyroid storm include patients with a large thyroid gland that is highly I-131 avid who receive high activities of I-131 therapy, Patients with rapid turnover of iodine are also at increased risk, meaning patients for whom the 4-hour I-131 uptake exceeds that measured at 24 hours. Thus, they are rapidly taking up and thereafter rapidly processing the administered I-131. For those with risk factors of thyroid storm, pre-treatment with methimazole or propylthiouracil can be considered to deplete thyroid hormone stores, but must be continued at least 3 days prior to I-131 therapy. Treatment with beta blockers can also be helpful for symptomatic control. Next question. True or false? Beta blockers need to be discontinued prior to I-131 therapy. The answer is false. Beta blockers do not need to be discontinued prior to I-131 therapy and can sometimes be helpful during therapy, as we have just pointed out. Next, what are other potential side effects or symptoms patients may experience after I-131 therapy for hyperthyroidism? Beyond initial possible transient worsening of hyperthyroidism, including possible worsening of Graves' ophthalmopathy, these include a mildly painful radiation thyroiditis, dysgeusia, which is an altered sense of taste, and recurrent laryngeal nerve palsy. For patients with a large goiter causing compressive symptoms within the neck, these symptoms may initially become worse, as the thyroid may initially swell following I-131 administration, and this requires close clinical follow-up and consideration of supportive treatment to include possible use of corticosteroids if swelling becomes severe. Next question. Is de Quervain's thyroiditis treated with radioactive iodine? The answer is no. De Quervain's thyroiditis is not treated with radioactive iodine. This is a self-limiting disease, and one would not want to ablate the thyroid that is expected to recover on its own. Also, the hyperthyroidism is transient and self-resolving with de Quervain's thyroiditis, and thus does not require radioiodine ablation. Next question. What laboratory and imaging information should be reviewed prior to I-131 administration for treatment of hyperthyroidism? For patients with a history of diabetes or renal disease, renal function tests should be obtained to ensure kidneys will adequately clear unbound I-131 from the circulation. Results of thyroid hormone levels and TSH should also be reviewed. A negative pregnancy test for individuals capable of pregnancy should be assured, ideally within 24 hours of treatment. Iodine uptake from either I-123 or I-131 should be reviewed. A thyroid scan or a stimulating TSH receptor antibody study should be obtained to distinguish between Graves' disease, toxic multinodular goiter, or uninodular adenoma, and to exclude silent thyroiditis and fictitious thyrotoxicosis. Note that I-131 uptake values, but not a thyroid scan, may also be appropriate for patients with classic clinical presentation of Graves' disease. That includes things like an elevated anti-TSH receptor antibody, pretibial myxedema, and classic Graves' orbitopathy. If you have questions on some of these entities that I just discussed, I would refer you to my prior episodes on nuclear medicine and the thyroid. Last and final question for this episode. Is hypothyroidism common in patients with toxic multinodular goiter following I-131 therapy? The answer is no. In toxic multinodular goiter, the radioactive iodine uptake preferentially is taken up into the toxic nodules, and the remainder of the gland has suppressed uptake and is therefore not ablated. Note that many of these patients with toxic multinodular goiter will become euthyroid following I-131 treatment. The same principle would also hold true for a hyperfunctioning thyroid nodule. The background thyroid is suppressed, and the radioactive iodine is preferentially taken up within and preferentially ablates the hyperfunctioning nodule, sparing the normal thyroid parenchyma, and potentially resulting in a euthyroid state. If anyone wants more information on I-131 therapy for thyroid disease, I would refer you to the Society of Nuclear Medicine and Molecular Imaging I-131 therapy practice parameters, which can be obtained online. A link to this is provided in the free downloadable study guide, which you can access at theradiologyreview.com. This was a longer episode. I hope this was helpful for many of you. You can also download study guides for other episodes from theradiologyreview.com, or you can find the Radiology Review Board Exam Study Guide episodes 1 through 101 on Amazon, which can save you from having to download each of these study guides individually. That's enough for now. Keep up the good work and study hard. Remember, you have to study really hard to succeed on radiology board exams. So prepare to succeed. I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.
The Radiology Review is pleased to offer the Board Exam Study Guide, episodes 1 through 101, available for purchase as a book on Amazon or in Kindle version.